Welcome to the Physicians Lounge, a podcast of the Mississippi State Medical Association. The Physicians Lounge was created to provide ease of access to information and resources on current topics affecting healthcare. Joining us today are Dr. Paul Byers, Dr. Thomas Dobbs, and Dr. Ben Brock. Dr. Byers is the former state epidemiologist with the Mississippi State Department of Health and currently working at the University of Mississippi Medical Center in Preventive Medicine in the School of Population Health. Dr. Dobbs is the Dean of the John D. Bower School of Population Health at the University of Mississippi Medical Center. Dr. Brock is the Medical Director of the Adult Special Care Clinic and Associate Professor at the University of Mississippi Medical Center, Division of Infectious Disease. Thank you for joining us.
Hi, and welcome to the Physicians Lounge, a podcast from the Mississippi State Medical Association. I'm your host, Dr. Paul Byers, former state epidemiologist and currently a faculty member with the Department of Preventive Medicine at the University of Mississippi Medical Center. Today, I am once again joined by Dr. Ben Brock and Dr. Thomas Dobbs, and we are going to be talking again about HIV, but this time about screening, who to screen, diagnosis, interpreting those diagnostic tests, and treatment and referral of HIV. So welcome, gentlemen.
Thank you.
Yeah, thank you.
So I'm in my primary care clinic, and I want to, first of all, make sure that I'm screening people appropriately for HIV. Who are the people I need to be targeting?
The ones with a heartbeat.
Anybody and everybody.
Yep.
Yeah, everybody needs an HIV test at least once in their life, right? The United States Preventive Services Task Force has a recommendation that that's a routine test, right? Everybody should be screened. And I'll tell you a quick little story. A gentleman that I recently came in under my care, he's 68, late 60s, and he just kept getting sicker and sicker, and no one thought until the nurse practitioner in his hometown, around Monticello somewhere, decided, to really be comprehensive and found that he was HIV positive and saved his life. I mean, we got to be, and it can be anybody, right? We don't need to be, prejudging who might or might not have HIV infection.
Sure, and a lot of people that we see with new diagnosis have intersected with the healthcare system many times during the latent period where they, have kind of no symptoms.
Are there some people who should be screened more often?
Yes.
Yes, yeah, definitely.
Yeah. Young people, people who are sexually active and young, because about half of new cases occur in young adults and adolescents. Young is relative, but I would say under 30 or under 35. And people with any intercurrent STD, so it's a bacterial STD like gonorrhea, chlamydia, syphilis. If you had any of those in the last few years, then you automatically are high risk for HIV just because of the common risk factors there. Pregnancy, anybody who becomes pregnant needs to be tested for HIV in the first trimester, and then ideally in the third trimester again for people with those same risk factors. So if you're somebody who has high risk sex or a bacterial STD, they recommend testing again in the third trimester for HIV because some people get HIV during the pregnancy.
You can do it when you repeat your RPR.
There you go. Those are the big ones. People who inject drugs should be screened as well.
Mm-hmm. And one of the things that comes up is, I know some people are squeamish about ordering an HIV test. It's part of routine screening. And you don't have to get a consent to test for HIV, right? Do you get a consent when you order potassium?
Well, and they can run it on the same tube a lot of the time that you're already drawing serum for. So if you have somebody who's coming for routine primary care stuff, it's not an extra tube usually.
So it's worthwhile making sure that they've had an HIV test at some point.
Yeah.
And I'll tell you,
depending on their risk.
A lot of the people that I've counseled on their initial diagnosis will say, I'll say, have you been tested for HIV before? And they'll say yes. And I'll look back in the record and they've never been tested. And they'll say, well, I just assumed my primary care doctor was doing it as a part of routine care. So a lot of people expect for it to be done, I think in contrast to what people think is that, folks don't expect to get it done. And I'm not saying you should never say that you're doing it. Say, we're going to check you for everything routinely as recommended for routine care, and do it.
Should you do any counseling beforehand?
Not really.
Not routine.
I mean,
Yes, there's a couple ways to do it, but opt-out screening, where you just screen everybody in your practice as a part of your this is just how their clinic runs.
Right.
They are supposed to be given the opportunity to opt out. So, you're supposed to at least tell them that you're going to screen them for HIV. We do this on everybody. It's no big deal. We're not, this isn't targeted
Just part of
screening.
your
We're
normal.
just letting you know that we're doing this test.
Right.
But, as outside of the era of paternalism in medicine, we're really supposed to be informing them about everything we do, any test we order or medication we start anyway. So,
and I'll say, I'll be broad. A lot of times I don't say HIV specifically. I'll just say, because we don't counsel everybody on everything we do, right? I don't tell them I'm getting LFTs. They don't know what that, folks don't know what that means. I'll say I'm going to check you for everything, for sexual health and, blood,
Right.
kidneys, all this, everything. I'm going to do a comprehensive test, inclusive in that, broadly, without sort of, picking out anything specifically, because sometimes that can be stigmatizing. But that's part of the art of medicine, I think, is dealing with your patients in a way that's both respectful, but doesn't have any stigmatizing, approaches.
some programs that, focus on HIV screening, do it in the context of wellness, like they're getting their blood pressure, cholesterol, like at a health fair,
Right.
and normalizing it as a part of a wellness screen.
And that's ideal, for sure. Okay, so I've ordered an HIV test, and it comes back. Is a positive a positive? Are there false positives?
Ben, have you ever seen a false positive HIV test?
Yes, and in people with tuberculosis and weight loss. There have been times where I was convinced that this would be a positive, and it ended up being a false positive screen. HIV diagnosis, like a lot of things, is a two-stage algorithm. So, you get a screening test where you want to, it's sensitive but not as specific. The specificity is actually pretty good too, but you want to catch everybody who has HIV with a possibility of some false positives, and then a second test that's a confirmatory that confirms the diagnosis. So the first test does an antibody and an antigen test together, and so if it tests for either of those, and then the confirmatory test is an antibody test. One of the challenges there is that you can have a false negative confirmatory in that first few weeks, because it takes a few weeks for your
Right.
body to produce antibody. So if you
You
end
may
up with,
miss that window.
yeah, if you end up with discordant results where that screen's positive, but then your confirmatory test is negative, you're supposed to order a PCR, and some labs will automatically do it, but it could require them to have come back in for a second blood draw to get that PCR done to confirm that it's actually a false positive screen.
So pay attention to the results of that two-tiered.
Yeah, they
Test
need
for
two
sure.
positive test results to confirm it. Yeah.
Right. Okay, so now I've confirmed it. I've got two positives. And the patient comes back into the office. What do I need to be thinking about first? Do I need to be thinking about? I need to get this person on treatment right away. I need to draw some additional labs. What are the first steps I need to do in my clinic?
Acknowledging the emotional reaction probably is the first thing. You really don't want the patient to have a negative experience during this visit, and have them discount the healthcare system altogether, because some patients have an unsavory experience with their HIV testing and counseling, and then they decide just to go their own way. So you want to be empathetic and kind, and acknowledge that it's kind of like getting a diagnosis for another life-limiting illness that can really cause a big grief reaction and denial. And if they have denial, acknowledging that and trying to be as empathetic as you can and objective.
It's an interesting question, because I've only had to do it in the context of our situation where, we can whisk them into the clinic immediately. We can sort of envelop them with the support that they need. But it's a tricky conversation, and I don't know how everybody has their own style, but I think there's some key points that are important to remember. when we're talking to people about this, and one of them is be clear, right? I mean,
Right.
make sure that you know what you're talking about, but also that you did test positive for HIV infection, right? Don't use any euphemisms or whatever, so people need to know. But also too, I wanted to really kind of reiterate that, we have remarkable treatments, and we have mechanisms to make sure that you'll get the treatment that you need, regardless of ability to pay. And then usually, and certainly it depends on the circumstance, but if someone is asymptomatic, I'll say, look, if we get you in care and get you on the right treatment, your life expectancy is essentially going to be normal if you're, on the right treatment regimen. And just, it's, I don't usually say it like, it's not, people will say, oh, I thought it was going to be a death sentence. And just try to, don't use the negatives. I try not to use the negative words, always just positive words. But we can help you through this. And it's something it's a big deal, and we get it. But it's nothing that, can't be addressed.
Yeah. HIV is a manageable illness, just like hypertension. It's easy to treat and completely manageable.
And if you looked at your sort of like your likelihood of early mortality, it's going to be much higher with diabetes than HIV in the context of proper treatment. It's just that diabetes is not a stigmatized illness.
Agreed. So I've done some counseling. Should I, in my primary care clinic, should I go ahead and try to start treatment or referral? And I also need to throw in here that one of the first steps needs to be reporting that to the Department of Health, who can also get someone plugged into linkage to care.
Yeah. I guess the diagnosing clinician first needs to decide if that was asymptomatic screening or if the patient had symptoms. If they were symptomatic that prompted the test, it probably had to be decided if they need to be evaluated in the hospital to determine if they have an AIDS-related condition that needed acute treatment. If they're just asymptomatic screening, then I think an ambulatory referral would be appropriate to a Ryan White clinic nearby to get them on medications. The challenge with it's really, there are a couple of single tablet regimens that are easy to prescribe and
Right.
they work great. The issue is the payer. If they
Right.
don't have insurance, they're not going to be able to afford it. And if they do have insurance, it's likely that unless they're like Mississippi Medicaid or something, then their copay will probably be really high. And they may not have the resources or the knowledge to be able to kind of manage how to get those patients affordable medications.
But you don't want to delay
You don't
the
want to
start
delay.
of those medications.
Yeah. How I usually pose it is it's a chronic illness, but we want to get you on treatment sooner rather than later. It's not an emergency in the matter of days, but we don't want years to pass because with some people will get sick within a year or two. So sooner rather than later, but ideally linkage, one big metric is usually like within 30 days of diagnosis that they've completed an appointment at a Ryan White clinic.
And the other component of this is important to keep in mind is treatment prevents transmission, right?
Right. So
This
tell
whole
us a little bit about that.
concept,
And
yeah.
that's viral suppression.
Yeah, so if we treat people who live with HIV and their viral load suppressed, they basically can't share it, right? Undetectable equals untransmissible, I think, is the U equals U sort of like little slogan that folks use. And the last I checked, I don't know if it hasn't been changed, but I think anyone who has a viral load less than 1,000, I don't know that there's been documented transmission. But certainly if you're undetectable, then we still want people to use condoms and stuff like that too. But just think about the benefit that you're providing to that person, their contacts, their spouse, all that kind of stuff. There are downstream benefits to everybody the sooner we get people on antiretroviral treatment.
And so once you refer that patient and say it comes to one of y'all's clinics, what are some of the first things that y'all are doing? Treatment, obviously, getting started on medication. Are there concerns about other infections that that may not be readily apparent? TB, hepatitis B, hepatitis C.
Sure. Yeah, we screen for viral hepatitis, bacterial STIs, gonorrhea, chlamydia, and syphilis. Everybody gets a TB infection screen, like a quantiferon or a TB skin test. Those are the big ones.
When folks come into the clinic, there's several things we'll do, right? Like Dr. Brock said, we'll screen them for everything. But also, too, depending on, we'll want to do assessment of their immune function. And a lot of that's going to be getting a CD4 count assessment. And so if their CD4 count is low, specifically less than 200, we'll need to add antibiotic prophylaxis, especially for PCP, right? Mm-hmm. Pneumocystis pneumonia. Also, you'll do examine somebody because it's not uncommon for someone to have thrush, right? And then we'll treat them for that, which is going to be an indicator of more advanced immunosuppression. So, part of the thing is to kind of figure out where people are as far as also, what kind of infections they might be coming in with, TB or hepatitis or whatever, do an immune assessment. We typically will send people out of the clinic with meds that day. I mean, we want, and I think a lot of that is not so much about, and part of it is trying to get people on treatment as quickly as possible so we can get rapid viral suppression, but it's making sure that we've sort of crossed that gap. We don't want to lose people in that sort of transition from engaged in care to engaged in treatment, right? Every step along the way is a potential place to lose somebody. And if you can sort of just evaporate that gap, then you've already sort of closed that, start that sort of treatment habit.
And so what are some of the referral resources? I know we've talked about this in other podcasts, but how does that primary care provider get to the right resource to refer their newly diagnosed HIV patient?
Active linkage is preferred. I think somebody picking up the phone and calling the nearest Ryan White clinic and doing a warm handoff is probably the best way to do it. Faxing a referral with relevant, test results included in the referral is, another way to do it. The university accepts referrals, but there are multiple clinics across the state that, have an HIV practice and a Ryan White program embedded. I mentioned previously there's a search engine on the HRSA website, findhivcare.hrsa.gov, that lists at least all the Part C recipients, but there are some other clinics in the state that do Ryan White that might not pop up on that list.
And if you don't know, you can always call your, ID colleagues. They'll know kind of where those resources are, but also too, the local health department does have, as part of their mission, is to do this investigation to make sure that folks are identified and linked into care. So that's
have an appointment somewhere.
Yeah, they can make sure that they make that connection. It's kind of part of their responsibility.
Yeah, and not just having the appointment; they're supposed to confirm
follow
that
up
they
to make
actually
sure that
completely complete the appointment. Yeah,
right.
Yeah, absolutely.
So, is keeping somebody in care a problem that we see once somebody gets started? Do they tend to stay in care?
I do want to say something that's a little bit different than that, and like what can the community physician do?
Yeah,
so
please.
Once you find somebody in your practice who might be infected with HIV, keep them. I mean, send them for treatment, right, for the HIV, but maintain that sort of relationship.
Don't just cut them loose.
Yes, yeah. I mean, because people have a lot of other problems, and what we find in the clinic patients that we take care of, the HIV part is the smallest part of the things that we have to worry about from a medical perspective. It sounds kind of crazy, but probably 90% of my time in an encounter is dealing with issues external to managing the HIV, because that's actually technically one of the easiest parts of it. And people need help with depression or high blood pressure or cholesterol or diabetes. If someone's in the community and they end up getting the flu or whatever, they can't drive to Jackson. They need to be able to go to their local physician.
They need to stay engaged with that primary care physician.
So it's a partnership, right? It's not so much a transition to somebody
turning your
else's care.
patient over.
Yeah. We're those of us who do HIV care are excited to be partners in taking care of the folks, taking care of patients.
No, that's great. Yeah. And I think I was asking about when somebody's in care, do they tend to stay in care? And obviously, it's keeping that relationship with their primary care physician is going to be one of those things that can help make sure that they stay in care. But does that tend to be a problem, or once somebody starts, they're in?
Yeah, they drop out two different times. It could be in that initial linkage period when they're diagnosed, but they haven't really established care with us, or during some time when they're engaged in care and then they're lost to follow-up. That first group of people is where we put most of our resources, because it's we're more successful in linking somebody after diagnosis. For those who are lost to follow-up, our success rates in re-engaging people once they're dropped out are much lower. It's a much more challenging group of people to get back in.
And we now have somebody who's stayed in care. They're virally suppressed. You had mentioned life expectations. Do we expect a normal life? Are there going to be potentially some long-term complications from the antiretrovirals? Are there other complications that can occur from having HIV for 20 years?
I guess it depends on when they were started on antiretrovirals. We do have patients who have been on medicines for 30 years. And for those who were exposed to the ART from the 90s, for instance, they often have lipodystrophy, more frailty, that sort of thing. So that's what we're seeing with our older population of people with long-standing HIV. How much of that's due to the HIV versus exposure to the medications is hard to parse out. But certainly that phenotype of patient is different than the patient of today who's diagnosed today and starts antiretroviral therapy. The medications today really are not associated with lipodystrophy and other long-term side effects, so they're very well tolerated. Weight gain is actually an issue with our newer medications, and so that's something that we're contending with, and we don't really know how to address that. What's strange about HIV and comorbidities is that it's actually the comorbidities of aging, like cardiovascular disease and frailty and dementia, cancers, that are more common in people with HIV and are coming on a little earlier in life. And so, yes, the HIV is well controlled and they're not developing AIDS-related complications, but the internal medicine practice side of it is more complicated in people with HIV. Mm-hmm. And then you compound that with the social determinants of health, where people with HIV have more poverty, less access to healthy foods, walkable streets, all those kinds of things, higher smoking rates. And so that compounds on whatever the virus is doing at the cellular level to cause people to sort of age faster too. Mm-hmm. Yeah. So it's a complicated management of kind of the chronic comorbidities.
Yeah, so you just really want to make sure that you're attuned to that, right? So cholesterol management, using HMG-CoA inhibitors, that sort of thing, and even at a lower level than I think, Dr. Brock was part of a study, I think, that showed the benefit of starting statins early. And so those are important. And in my patients, the biggest threat to their longevity is smoking. Mm-hmm. That's something I try to pay a lot of attention to in the clinic, is because that's the thing that's going to take them out early. Yeah. Those folks who are engaged in care and taking medication, they're doing great, but if they're smoking, that's what worries me more than anything.
Gotcha.
Yeah, in the last decade, at least in our clinic, we've really realigned expectations, where I think 10 years ago, we were in damage control a lot of the time with patients, just trying to keep them on their antiretrovirals, and things like hypertension management were kind of on the back burner or not real high priority, and we just wanted to get people their HIV controlled. But now, knowing that they have a higher risk of heart disease, for instance, than an HIV negative person, we have an even greater indication for aggressive blood pressure monitoring, management, and cholesterol management, and that sort of thing. So I take that very seriously in this patient population, and we've got them on the whole metabolic gamut of medicines. So,
well, very good, gentlemen. This has been very informative. Any final thoughts?
Yeah, the only thing I want to say is I always try to reinforce to folks that, HIV is entirely treatable. People can live long, healthy lives, and they can always get access to treatment. You just got to get them to the right place. So it's, I think people ask me sometimes, they say like, oh, it must be depressing. I was like, it's fantastic. You can help people live where otherwise it might be a real challenge. And also too, you have within the infrastructure of like the adult specialty care clinic, you have, a resource network that helps when you can go and you can say, someone says, I have housing insecurity, I have food insecurity, I don't have transportation issues. If you did that in my private clinic in years past, that would be well beyond my capacity to do anything for, but we've got a great team of people who are super talented and committed. It's a wonderful place to work, and it's a great field.
Yep. Screen. That's what I would say. The whole goal of all this asymptomatic screening is to try to get people on medicines before they develop symptoms. Their long-term outcome is going to be so much better if you diagnose them when their CD4 is 500 than when it's 5. Really getting as many people on treatment during that early stage of HIV rather than later is the goal. We have way too many late diagnoses in Mississippi still, and the only way to move the needle with that is to do more asymptomatic screening. So anybody who's in care, test.
You heard Dr. Brock. Screen. So thank y'all again.
Thank you.
Thank you.
Thank you for joining us. Show notes for this and MSMA's other episodes are on podbean.com or on msmaonline.com. Support our show by subscribing and leaving a review. Thanks for listening, and see you next time. Brought to you by MSMA. We are the physicians who care for Mississippi.